Good morning or afternoon, everyone. It's good to see your faces. Can you guys hear me? Okay, all right. Yeah, it's been a while since we've had our community conversation, so we're excited. Robin is, I don't know if you're listening, Robin, maybe. Says she is.
I am,
Robin,
I'm here.
Oh, okay, great. Robin is sort of in transit, heading back to Hawaii, right, Robin, now?
Yes, I am.
Yeah. So I'm gonna be hosting with Dale, and we're gonna update you all on what's going on with not just COVID, but things in general, and how to manage your practice around those issues. We had a little practice session yesterday, and Dale has some really good information. So we have 50 people signed up today, which I think might be a record. And Sophie is our, Ashley, our normal other host, is actually almost ready to deliver and having some issues with that. And so Sophie Schwartz is going to be filling in for her. And so you'll see Sophie's face on some of our events, and she's going to be, excuse me, just checking the chat and making sure that everybody gets in. So, and there's Dale.
Yeah. So we're all set. Should we get going or give it a minute?
We are all set. I want to see, we have 24 participants. So, I mean, I think we can start. Sophie, you just keep letting folks in as they join. It's so fun to see you guys, everybody's faces. It's been a long time, it feels like. Although that was just January, our last one. So if you have,
feels longer.
Feels longer.
Yeah.
If you have questions for Dale, as long as, or anyone actually during this, just put them in the chat and we will address them either as we're going along or after Dale speaks. And also we might ask some of our members who have experience with some of the issues we're talking about to chime in if they have information as well. So with that, I'm going to let Dale take over. And as you all know, Dale's on our board, but she's also a physician who is a director of OBGYN at Swedish, and probably might address some of her specialty issues today.
Yeah,
Okay.
I'll keep it mostly general, but good morning, and it's good to see you guys again. It's 2022, and we're not done yet, but it feels better. It feels like we can breathe, and so I'm going to talk a little bit about what that means and where we're at. So, you know, I typically start with data, and I'm going to do that again. The data I want to talk about is looking at, we'll start with a basic of where we're at with global and both US in terms of total cases, but then I'm going to quickly go into some subsets of data that might be interesting to you as individuals or as advocates. So across the world, we are over 458 million cases of COVID. Over 6 million people have died from it. In the US, we're close to 80,000 total cases. And of course, you know that our case numbers are not accurate because there was such a long period of time that we were not actually testing people. And our total death rate that's specific to COVID is greater than 964,000. So that doesn't, and I haven't seen anything lately estimating, but that does not talk about the deaths that may have occurred from people not coming into the emergency department till it's too late, or not getting surgery done that might have saved them. So that's the incidental related, but not direct related cases. we know that our hospitalizations and our vaccinations are inversely related. And we'll talk a little bit about that. Our hospitalizations have dramatically decreased from early February to where we are here in March, so mid-March. So it just in a really, 1 month to 6 weeks period of time, dramatic drop in those. And what I wanted to highlight is the difference in who gets hospitalized. So we'll talk a little bit about that. If you look at age-adjusted rates of COVID-19 and hospitalization, so you don't get hospitalized unless you've got severe disease, right? So at least moderately severe to severe. And so if you look overall, the rates are 6 times higher for hospitalization in unvaccinated adults aged 18 and older. When we look at children 5 to 11, it's 3 times higher. In that, when you look at the peak, it actually got to 7 times higher during the Omicron period of time for hospitalizations in that 5 to 11-year-old age range. So pretty dramatic, and that was at the end of January. In the teenage group or preteen, it's 2 times higher. And when you get to unvaccinated adults in the 18 to 49-year-old range, it goes to 5 times higher, stays 5 times higher up to age 64, and goes to 8 times higher if you're 65 or greater. So we'll circle back around to this at the end of the discussion, but just it makes sense that we knew from the beginning that the older population has a higher risk of severe disease and death, and that has held across the line with the more highly infectious Omicron variant. The unvaccinated adults, so those were overall statistics, it's 12 times higher for age 18 and older for hospitalization. 18 to 49, 8 times higher, 50 to 64, 10 times higher, and 15 times higher in those 65 and above. So pretty dramatic differences between those who are vaccinated and those who are not. And of course, there are other breakdowns. The CDC doesn't have done graphs on or data tables on those with other comorbidities that make them at higher risk. So anyone who's immunosuppressed, obviously, and others that have comorbidities that we know are risk factors for COVID. That might be obesity, that might be hypertension, diabetes for sure, some of the other chronic autoimmune conditions also. I'll hammer through a couple of other things data-wise and then open it for any questions, because I think that might be a good point if people have questions. The pregnancy data, I think you've heard me say, for those of you who have been on the call before, that in pregnancy, our vaccination rates really lagged because none of the initial trials included pregnant women, except for when it was accidental. So like first trimester and somebody didn't know, but they purposely did not enroll pregnant patients. And that's typical for most new trials. So there was a real delay in pregnant people undertaking vaccination, feeling like that wasn't entirely proven safe, and not a strong message from the national organizations like the American College of OBGYN and a Society for Maternal Fetal Medicine, Family Medicine, et cetera. The Certified Nurse Midwives national organizations, they didn't come out strongly till like a year ago, basically, about vaccination for pregnant people. So what we saw was really low rates. And then as the information got out, they started increasing. And what's really fascinating is that the highest vaccinated population is within the Asian community. So that would include Eastern Indian, that's included in Asian, as well as, all of the traditional, Japan, China, those types of areas. Over 80% vaccination in pregnancy or before pregnancy.
But do you know why that is, Dale? Like what, I mean.
I think it may be education, but
Education.
I don't know.
Okay.
Yeah.
No, I'm
Because if
just
you
curious
look at-
because, yeah.
Yeah. Because, they are people of color, but they have a different place in our US society. A large percentage of the Eastern Indian population are highly educated here, working in very, specialized industries and things like that. Most of them had occupations where it was easy to get vaccination, and so on. But that's really fascinating. That's across the entire US. And the lowest is the Black population. So that includes African-American and Black immigrants. And that runs probably around 50%. And this is for those who are fully vaccinated, okay? Then it started out with some pretty wide discrepancies between Caucasian, Hispanic, and other in the beginning, and then now has pretty much clustered around the same, just below 70%. So again, this is pregnancy, and I think kudos to all of the prenatal areas in the hospitals that decided to offer vaccinations to patients when they had interactions within their triage or that sort of thing, but really a lot of work done prenatally. Over half the pregnancies, or at least half the pregnancies in the United States, are unplanned. So it's really hard, not necessarily unwanted, but unplanned for this moment. And so it's really hard to capture people before they get pregnant sometimes. And so really for the people that provide prenatal care and really reassure pregnant patients that vaccinations were safe and that the disease itself was not, was a big deal. And I think we also had in the second year, with the high contagiousness, we had a lot more data on how devastating COVID can be during pregnancy for both the delivering person and the baby. And that information was getting shared more broadly as well. So that I think is helpful to know. And then the one final thing I wanted to talk about is a little bit more on race ethnicity data. Fascinatingly, and this is looking at not fully vaccinated, but at least one dose. Okay, so it's a little bit different than the data I just talked about for the pregnant population. The highest with recent vaccination and more than their population percentage is in the Hispanic or Latino population. And I think that may be because these are a lot recently in the last few weeks. And so again, the infectivity of Omicron, the expanded access and continued access discussions about vaccination, getting into more rural communities, I think probably has affected that. So the Hispanic population across the country is about 17% now. And they're about 22% with at least one dose of vaccination. The other group I wanted to comment on is the Black or non-Hispanic Black population in our country is about 12 to 13%, and their rate of at least one dose is right around 10%. So under their population. It's better than it was. And we do have more people who've been vaccinated in the last couple of weeks with their first dose. And then the Caucasian population in the United States is 61%. There's a chunk of multiple background people that identify as, mixed race. But within that, about 55% have had at least one vaccination. And most of them, or more of them, have had their first dose or their one dose at least in the past, not just in the last couple of weeks. So a little bit different information about access to vaccination, probably in motivation to get vaccinated. And then the final thing I was going to talk about is those getting boosted. And that runs differently, lowest in the Hispanic population, but that's probably because they don't, this says eligible, but because they had fewer percentage that got early vaccinations, there's probably fewer of them that actually were eligible. I don't have total numbers. And the highest that are boosted in Asian population, which sort of mirrors the data I talked about for pregnancy, with Caucasians second and multiple racial identification as third. So just a little bit, some people are not choosing to boost. And we can talk about boosters and subsequent vaccinations because I do want to talk about that next. But I wanted to see if there are other questions or comments. If anybody else has other populations to talk about before we move away from the data.
Maggie, do you want to ask Dale your question directly? Maggie Pheasant.
Yeah. Oh, go ahead and unmute, Maggie.
You have to unmute.
Yeah.
I'm sorry, I think I missed this when you were talking about at the beginning who gets hospitalized, and you talked about 50 to 65%, 10 times higher.
Mm-hmm.
I didn't know if that were all of those were unvaccinated when you were talking about 50 to 65.
Yes.
10%. Huh?
Yes.
Okay.
The 10% higher in that 50 to 64 range is in unvaccinated adults, and only adults, not children. So that data comes from age 18 on up, does not include children.
Okay, thank you.
Sure. Anybody else with some clarifications or questions or thoughts about any of this? Nancy. Hi.
Hi, dear. Thank you so much. This is wonderful information. I just threw in there multiple sclerosis because you were talking about all the immunocompromised people. I got hit pretty bad after my vaccines, each vaccine and the booster. I got pericarditis, and I know people in my support group of women have also been hit really hard. So even though we got vaccinated, we got hit pretty bad, and now I have a heart condition. So there's a lot of side effects from the vaccine.
Right. And I'm sorry that happened to you. Yeah, that is so hard. Yes, there's no panacea. There's nothing that's perfect. And when we talk about vaccination, we're talking about populations, not individuals, and not that we're ignoring you as an individual, but the overall benefit in terms of loss of life and so on. We've talked a little bit about folks with long COVID too, whether they got boosted or not, with some very interesting data that some people actually had improvement in their long COVID, but some people did not. And you don't know upfront who you're going to be, right? So that is, in fact, a really, really hard thing to think about. I think women of reproductive age should be, if they're vaccinating and they haven't been vaccinated yet, should be not looking at Johnson & Johnson. They should be looking at either Pfizer or Moderna. But you're right, everything has a risk and a benefit. And I wish we had that crystal ball to know if you were the person that needs to avoid the vaccine, or if you're the person that really needs it. I really think, and I'm going to end with the same comment pretty much, we have to look at our own individual situations and determine what's best for us. And sadly, sometimes those choices, which were really valid choices to make in the first place, don't go the way we want them to. So thank you for speaking up. I really appreciate hearing that from you. Yeah.
Actually, Tina Vandenbosch put a chat in, and Tina, if you'll unmute, I'll let you go. And then Maggie Buckley has her hand up as well. There you are.
Okay, can you hear me?
Hi, Tina.
Yeah.
Yes.
Hey, good morning. So I just put in the chat, I'm curious if in your OB population, if you guys have seen an uptick. I mean, I know thromboembolic issues have definitely been big with COVID, but I'm curious to know if you have seen SCAD events, spontaneous coronary artery dissections, in the healthy pregnant population. There has definitely been an uptick in this type of heart attack in women since COVID began, and I happen to be one of them. Had an event while running without any risk factors whatsoever, and it followed. I had breakthrough Delta 7 weeks prior to my cardiac event.
Yeah.
And, so I'm finding that in the general population, the number has gone up, and I'm curious about the pregnant population as well.
Yeah, I'm relatively up to date with what we're seeing in the pregnant population. I don't think we have seen an increase in that particular diagnosis over and above some of the other things. We are seeing much higher rates of preeclampsia. We're seeing interesting and sad, occasional, not high rates of fetal loss, stillbirth, a month after an acute infection, where the mom might have had even a mild infection. In fact, most of those cases that we've seen, their isolated case reports have been after a mild infection. And then a month later, all of a sudden something's going on. And there is evidence of placental dysfunction when you have somebody who knows what they're looking for, look at that pathology. So there are some things that are kind of unique to women. When it comes to thrombotic events, initially there was a suggestion there was a higher rate of thrombotic events, and some people were recommending using heparin for the sick admitted pregnant patient. It's not really clear that that's true in terms of looking at the last 2 years. So we're still trying to pull together all the data we can about what's unique about pregnant women, or women in the reproductive years, and separate that out. So yeah, I think it's really important to hear those things. I'll kind of keep an eye out for that. I'm on our Washington State Maternal Mortality Review Committee, and we're just starting to look at COVID deaths in our state. Fortunately, our numbers are not super high, but they're all heartbreaking. And in the obstetric population, boy, one of the highest risk factors is being obese plus pregnant for really severe COVID. Yeah.
So Maggie, can you unmute so you can ask your?
Yeah, thank you. So I have two comments here. One is about the susceptible autoimmune people, and one is about SCAD. and you'll understand why they tie in together in a moment. I deal mostly with the connective tissue disorder community. And so there's a high incidence of mast cell activation disorder in that community. So initially people were reluctant to get or give a vaccine in people with mast cell activation disorder. And then what they figured out is that if people were keeping up with their treatment regimen for mast cell activation disorder, they had much fewer side effects and almost no consequences to the vaccines. And they also found that people who were not diagnosed actually were at higher susceptibility for COVID complications and for long COVID. So within that community, they've adjusted the recommendations for this very susceptible group of people, both with mast cell and with connective tissue disorders like Ehlers-Danlos syndrome. The one thing. And then that carries through to SCAD, or spontaneous coronary artery dissection, which is also very common in this population. And what we found is that there's been a higher diagnostic rate of people with connective tissue disorders after they have a SCAD, which makes sense because one of the theories that's been there for about 30 years is that there's an infection that triggers an extreme response that then makes this genetic connective tissue disorder more obvious or something to consider in that way. So, you know, I'm sure, Dale, you're nodding your head. You're like, yep, I've seen that. Because something like that happens, and then they're grasping at straws and they're like, well, let's do a genetic panel for that, which we could do now, which we couldn't do even 10 years ago. And they're saying, oh, you have this collagen defect, which would explain that. And what triggered it was probably the infection. And so there's lots of help and support and information out there on how to manage these people, these people that have these complications. And the research is ongoing and the publishing is ongoing, and we're learning so much more in this time about the mechanisms, the underlying mechanisms. So I, you know, initially I wanted to say, Dale, are you seeing that? But you were nodding so vigorously.
No, that is so right. And I think the genetic stuff, you know, it's a double-edged sword, right? Because people are finding out stuff that they don't really want to know about. We're, you know, talk about interesting sperm donors and things like that, you know, looking at the genetics of biology that people thought was one thing and isn't another. But we've known for a while that genetic propensity, even if we didn't know the gene, was sometimes triggered by viral infections, usually more severe than the common cold. And so this makes a lot of sense that we have these underlying conditions that we might be susceptible to. And in a perfect world, we don't get that disease because there's nothing traumatic that happens to our immune systems. And we also know that if your immune system is disarmed a little, like what pregnancy does, which has to be, because otherwise we reject the fetus. So we want our immune system to downregulate a little bit. That's when some other things show up. So like a very common time that we diagnose lupus is in and around pregnancy. So that makes a lot of sense, Maggie. And thank you for sharing that. That's really fascinating.
I just wanted to underscore, you know, the importance of finding a way to make vaccination possible, one, and that when you're presented with unexpected consequences, to look a little deeper or help your clients look a little deeper and find resources, because there's a lot of explanations out there. And pregnancy is one of the most common times to have all types of Ehlers-Danlos syndrome diagnosed. because of
Yes.
all of those things and
Mhm.
the hormones, which make us even floppier.
Yes, yes. So
Thanks,
and
Maggie.
the other thing to think about for your clients and or yourself, if you're one of these people, is, you know, figuring this out for your offspring is really
Mhm.
important as well to
Mhm.
know. And I'm not a big advocate of everyone running out and doing 23andMe or whatever happens to be the latest, you know, way you can do your genetic makeup. But I do think that when we come down with a disorder, that we now can diagnose in a way we couldn't before, that we want to know that to share with our family members because they may be a carrier as well, that kind of thing. So as we get more and more information, I know this is a little bit of the COVID conversation, but not really, because it really talks about we all have individual susceptibilities and sometimes we don't know what they are till we get hit with something. So yeah.
Right.
Yeah.
Well, and Maggie, I think most
23andMe, yeah, 23andMe, I just want to interject, is not a reliable way to
Yes.
diagnose any of the
Anything.
connective tissue disorders. It needs to be a genetics counseling referral,
Specific.
whole
Yeah.
exome sequencing, because we have identified so many of the genes in the last 10 years.
Yes.
Well, and Maggie, I
it's-
want to say I appreciate what you said for our advocates in our community about if people do have an autoimmune disease, to make sure they're following their treatment plan, because that
Mhm.
is really, you know, critical, whether they're, you know, and then getting the vaccine, of course, but making sure they're not, you know, falling off their treatment plan. So,
Right.
Yeah. And if you really are someone who can't get the vaccine, to protect yourself in other ways. And we'll talk about this at the end as well. It's nothing new, but just to make sure. Let's see, do we have one other question in there? D?
We have D, and she asks, have you heard in reported literature an increase in embolic strokes in the general population getting a vaccination?
I have not specifically with strokes. Yeah.
Okay, thank you.
There, like I said, there's that vague suggestion that that there is increased thrombotic events potentially with the wild disease, and we don't know everything. So I would keep open to whether that's related or not. The problem is strokes are really quite common, and they all have a different etiology for how you get them, right? So there's some that are hypoperfusion, like you're not perfusing your brain enough and you get not enough blood flow, and so the brain tissue dies. That's a type of stroke. You have hemorrhagic strokes that may more commonly associated with hypertension. You have anomalies. So if you have an aneurysm or something like that, and other venous anomalies. So strokes are a kind of a catch-all for a lot of internal brain injuries that are from different etiologies. So we'd want to know about that if that starts showing up. Yeah.
So the thing that we talked about yesterday that I think would be so interesting is your discussion on how going from pandemic to endemic and what we need to do now. Like, And
I am going to talk about that, and it's not a long amount of talk, so it'll give us plenty of time for more discussion. I think we're on the, right now there've been a few more identified variations, and so we could certainly see another wave. It feels like Omicron, as infectious as it was, did us a favor, because so many people got sick. And so you saw the increased vaccination rates, so across the entire country, it's in the 71% of fully vaccinated, not necessarily boosted, for adults. And so between the wild disease, at least transient immunity, whatever length that really is, and the higher rates of vaccination, we have a pretty protected population right now, which means that the virus can't really establish itself as well And we've seen certainly even in those who get breakthrough disease, certainly milder cases. It's when we don't have an open host, then the virus tends to drop off, and it can't continue its life cycle without a host. So it's, you know, it's out there, but it still needs a host in order to take over cells and do its job to stay viable. So what we're seeing probably with these decreases in cases is perhaps the movement from full pandemic to endemic. So what is that? So way long ago and far away, I talked about the definition of an epidemic and a pandemic. And so what I wanted to do is kind of remind us that epidemic is a sudden increase in cases of an infectious disease. And what we had to trigger that was from, say, December of 2019 through February of 2020. That was when we really had the onset of the true epidemic. And then it became in March a pandemic when it was so widely global. So the moment you start seeing tons of people infected in different countries, and it's not just a, you know, there and gone right away, then it becomes a pandemic. So to get to endemic, which is constant presence but low level, we need to have certain criteria met. And so I'm going to run through what these are. It's really straightforward. We need to have, and I already alluded to the fact that we're kind of there, enough people vaccinated or infected and recovered so that the host is not available. And that ideally boosters as needed, right? So when I think that's all muddy, we're not going to talk that too much. I'm happy to answer questions about boosters, but then what we end up with is that an annual vaccination recommendation or whatever. We need to have continued public health measures that are appropriate. So mask mandates are being lifted left and right. If you're in a grocery store or Target or one of those places, you know, Walmart, whatever is your big box store across the country, you may still want to wear a mask. And if you are vulnerable, I would suggest you wear a mask, even though nobody else might be. And now I'm seeing garbage on, and I hope I'm not offending anybody, but I think it's garbage on social media with people harassing those who choose to wear a mask because we're mask free. So why are you being an idiot wearing a mask? You know, that kind of attitude. And we will face that. And I'm going to continue to wear my mask in the freaking grocery store because I don't want to get sick, you know? So I think that, that those measures, really good hand washing and or gelling when you're in and out of public spaces, still a good idea. And you continue to use high quality masks. So it's pretty clear with how bad Delta and Omicron were that you get those KN95s and use those instead of the cloth mask. Or if you feel really much more comfortable in cloth, make sure you get that extra filter that you can put in there. And then the other thing to getting to endemic is testing. So testing is, I'm not going to spend a lot of time on this because I know it's a little bit controversial about who, when, where to test. You may help get to endemic by testing either prior to and or after a large family gathering, or if you're rejoining your church or synagogue in person, or other site of worship in person. If you are not masking, then you may want to test, within 3 days after that gathering. If you have slight symptoms, you may want to be on the light side of deciding to test at home, because then if you're positive, it doesn't mean you need to freak out. But if you're super high risk, you may need to go get some therapy, or you may wish to go get some therapy, like whether monoclonal antibodies are even appropriate, or the next thing that comes along, the oral, that may or may not be helpful to keep the disease severity in check. But at least you shouldn't be out circulating. So for me, I like to see myself as an example. So I'm old and have a couple of conditions that probably would say that I'm not overtly immunosuppressed, but I'm at higher risk. And I have a new grandbaby. And so if I think I have some symptoms, I want a home test and make sure that I don't go see my grandbaby who's, she's getting her antibodies through breast milk, but she's not able to get her own support for avoiding the illness. And I don't want to, if I have another friend who's also at risk, I don't want to be around that person. So those things allow us, and now that there are more inexpensive home tests available that are antigen tests that you can do yourself, it allows you to test yourself so that you are sure after an engagement that you aren't sick, and that you're also sure that you're not going to visit somebody that is. And that might work for you guys. I'll take your question in a second, Victoria. That might work for you guys as advocates too. If you're going to be, if you've just had a big family gathering and you're going to be meeting with an advocate, might be a part of valor to self-test. So those will help us get to endemic. And then looking at those treatment options if you are higher risk, and so that you're ameliorating your shedding of the disease and also your risk, your personal risk. So you have a question, Victoria?
Yeah, I have a house guest coming in May. I had a booster in January, so I will be due for one, I guess, in June. I don't know if we're doing that or thinking about it yet. She's had the disease. She's had the vaccination and a booster. She will be going to Mexico right before she comes to see me, and she will be flying from New York. And I don't know what kind of testing we should do to make sure she's safe to stay in my house. This is going to be a last visit. She's dying of cancer. I really want to see her, and I want her to stay in my house. And I'm scared to pieces. I'm immunocompromised, but I don't see the sense of having a visit if she can't be in the house. So is there a test that will distinguish if somebody's had the disease from antibodies that were made before? I don't know how to go about this.
Right. So what you would want to do, especially if she's traveling, I mean, there's two options for you. One is quick and easy, is you get a home test, and you have her stay in a hotel, pick up a home test, make sure she has it, stay in a hotel or stop someplace, get the home test. They take like 15 to 20 minutes to get the results. They're pretty reliable. You can occasionally get a false positive or a false negative. If you want the PCR, which is the gold standard, that takes a little bit more time and a lot more money to set up. And that you can order, if you have a lot of money, you can order home testing devices that do something very close to PCR. It's the along the lines of the NAAT, what the borders were requiring. Those are a 20-minute turnaround. But if you're going into some other place where you're ordering it, someone who's been traveling or whatever, if you can even get it, it's a several days. So
will the home test be reliable if she's?
It's about 95% reliable. So with you both being boosted, now I would test her. Here's what I would do. I would test her when she comes with a home test, and you can do it, have her stop someplace if you're really worried about it, or wear a mask and just have her test when she walks in the door. And if that looks negative, try to not worry about it. Or if you're really nervous about it, have her retest 3 days later.
Okay, but wouldn't she automatically test positive because she's had the disease and she's still?
No, she
having
won't.
antibodies?
No, it's for active disease. Yeah. So you can get those home tests, boy, I don't know.
I've got a home test. I just didn't know if
Yeah,
it was effective.
yeah,
So thank
yeah.
you. That answers my question.
Exactly. If she tests positive, don't freak out. Get her someplace where she can, there's lots of places. If you're symptomatic or think you're exposed, that will test you. It's just if you're just traveling, it's hard to get them. So yeah, if she were to test positive, I would go get it confirmed, because they can be a good 5% false positive rate. And so it's not the end of the world if she tests positive. Yeah.
Thank you.
Sure.
There's a question in the chat. Is there concern for a spike with the crisis in Ukraine because people are moving all over the world?
I wouldn't worry about one particular country like that. They are moving all over the world, and I'm happy we're welcoming them. I think that we will have to help them stay safe as well. There are there's more disease activity in China's got the biggest spike they've ever had, right? So, and that's where it started. The US is, everything's coming down. So yeah, we could, if what they're seeing is Omicron, we've been there, done that. And so you're probably in good shape being vaccinated. And so I don't think that's it. I think our risk of a spike is more if we get some Omicron like other variant that pops up. It's not clear to me that that's the case for the European cases that are happening right now. I don't think they're finding anything too weird.
Michael Wood asks, are the home tests that we've gotten from the federal government 95% reliable as well?
I think they probably are. I don't know what brand they are or anything like that, but the original Abbott quick antigen turnaround test runs right around that. And so the thing that's good to know is that those tests are most reliable within 3 days of an exposure. So that's why I was mentioning to Victoria that she could test her friend right away and then maybe consider repeating it 3 days later if she's immunosuppressed. And, they both, because you would want to be sure that you're watching your own self as well, if that's the case. So yeah, the home test should be the same as the ones that the drugstore is selling for $8 or whatever it is.
So Maggie Buckley asks, does it make sense, because as patient advocates with high-risk clients, or the potential of having high-risk clients, does it make sense for us to continue to home test at regular intervals? Early on, people, were catching up on preventative care. And so now, should advocates, and we talked about this a little bit yesterday, Dale, about scheduling screenings and getting back to, so maybe you can talk a little bit about for the advocate community.
Yeah. Before I launch into that, I do want to give you some things to think about as you're watching for what this getting to endemic. So there's 5 things that the public health officials will be watching for, and I can just run them off really quickly. And then we should talk about definitely the types of things Beth was just talking about. So they'll look at case numbers. Case numbers for us are only helpful if people are still testing all the time. And I'm seeing people back off on testing as the case volume comes down. So that may be helpful or maybe not. And the goal for case numbers for endemic is less than 200 cases per 100,000 people. So it's not a lot of cases, right? Less than 200 cases per 100,000 people. Hospitalizations, so we want hospitalizations to be decreasing and be at stable low rates from COVID. So they are decreasing. We're not at stable low rates yet. Death rates, the goal is less than 100 deaths per day in all of the United States. We are not close to that. Yeah. So that's the goal. There will be, in lieu of case numbers, and you might love this one. I think it's, you know, if you like potty talk, they do, they screen the wastewater that comes through the sewer. You may know this, for evidence of COVID. And that's probably our best way to figure out current active disease state, because you shed virus the most in the first 3 to 5 days of the infection. So they will continue to do that and report that out. So that will be another way. And I think that's probably actually more accurate than our positive case rates. So the hospitalization information and the death rates, of course, are valid. And then the wastewater probably is our better case assessment. And then they'll be looking for outbreak clusters. So if we stop seeing outbreak clusters from schools or community centers or, you know, religious gatherings and choirs and things like that, weddings, that will also be a sign. So those are the things to pay attention to in the news when you start seeing numbers reported. That will, I think we're headed that direction, and I think it will be endemic. It is not going to go away. Hopefully it settles into something like the season of the flu, where it's relatively predictable when the weather gets colder and we do more indoor things. And remember to still consider wearing masks and hand washing and physical distancing during those seasons. We've had dramatic decreases in even the common cold with all this masking, and certainly our flu season was a little worse this year, but nothing like our normal. So, so those physical things that we've been doing do make a difference, in separate from the vaccination. And particularly if you're someone who either doesn't feel comfortable getting vaccinated or really, you know, medically it's not indicated. So yes, we do need to get back to some of these other things that I mentioned, the indirect deaths. I know there's a big push for women to get their mammograms, their screening mammograms. A lot of people delayed those. I think we're in the Swedish medical system, we're trying to get our mobile vans up running again that go out to the communities so we can get to people that have transportation difficulties. And so you may see that. I'll highlight that we still nationally, and certainly in our region of Washington State, are experiencing blood shortages. So if you or someone you know can go donate, that is another thing that we can do that's very proactive for the people who need that resource. There are shortages of lots of equipment and medical supplies and medications. I cannot tell you, I don't know that a week goes by without us being short of something. Might be something as simple as, you know, baby bottles or nipples for those babies that need supplementing, you know, that kind of stuff. It's everything. It's amazing. But, you know, surgeries are becoming, surgeries are what keep hospitals open. And, you know, I know hospitals have a bad rep, and I know that not everything they do is correct when it comes to finances. But in this country, where we're still fee for service for a lot of stuff, that's where hospitals make money to float and, you know, cover the huge amount of staff that is necessary to run something like a hospital. And so those surgeries are back in full force in most places. And where it's not absolutely full is because there's not enough staff. So it's going to take a long time to get back to staff, and the rate limiting step is the amount of time it takes to train new people, because a lot of people have left, and it's not healthcare. I mean, it's everything else, right? The ferry system in Washington State is a mess because there's not enough people to run the ferries on the usual schedules that we've had in the past. And then there's this high demand for all of us to get out of town, you know, so that's you look at the hospitality services, that a lot of these hotels and destinations are not up to full staff and will be a long time before they do. People just decided, I don't want to do that job anymore, and they're off doing other things. I'm not actually sure how people are living because they're taking a break from something that was a salary, rather than like my old way of doing things was to just pony up and work and do my education at the same time when I wanted to do something different. So, but that's what's happening for everything. So as you try to get your clients back into the healthcare arena, we will continue to see virtual appointments. Some people really like them. It's a huge benefit for people with transportation challenges and people that are even more sensitive about exposing themselves in a waiting room. So there's nothing wrong with virtual visits when it's appropriate, and there's nothing wrong with in-person visits with caution for those people that really do need to, if you need blood work done or something like that. So I do think that advocating for folks to get back and do their colorectal screening or their anything else screening, super important. And to help people feel less intimidated about getting back in to get follow-up stuff. I've got a bunch of stuff myself that I need to start scheduling. I was on the verge of doing it, and then we got the fall hit with both Delta and Omicron, and I waited. So I know lots of people are doing that, and so that's an area I think you guys can be really helpful with.
Yeah, and just that communication piece that we've talked about before, because the staffing issues are so dire everywhere. I mean,
and you know what? You're going to run into some people that are ruder than they should be, and I apologize in advance. People are so burned out. I cannot believe how people I never would have imagined are snippy and very appearing to be self-centered, even though they probably aren't. It's just I think people's patience has really been drug out. I'm not saying that's an excuse for bad interactions, but I just feel like don't let that stop you. If you're advocating for somebody, make sure that you go out of your way to either skirt around that or address it in the moment. I'm sorry, I know you're overworked, but I mean, really, did you need to snap at me? I mean, honestly, I would do it. Yeah, nobody deserves to have somebody not be pleasant with them. So yeah. Any other questions? Because I know we're almost out of time here.
Yeah, we just have 3 minutes. So if anyone has a burning question, that was a lot of information, Dale. Thank you so much. Maggie brought up that, it would be great for advocates to have best practices around this. And I said, maybe Pac B so I will follow up, Maggie, and see if I can find out anything. I don't think Dale can put that on her plate, although she may contribute to it if we can develop something. I do think it might be a Pac B, something that they could work on, because certainly this COVID issue isn't going away anytime soon. So
yeah, and I want to thank you guys as a community. It's so great to hear from you, to hear your personal and your work experiences. It helps us as an advocacy organization. It helps me personally. I want to be able to provide information that's helpful for you guys when we do these conversations. We'll be trying to bring some guest speakers back in the near future as well, so I don't have to just always hear me. But I do really appreciate your dedication to your occupations and also to the community. It's obvious that you guys are awesome advocates. Thanks.
And a big thank you to Dale. This takes a lot of her time from her own profession. And so thank you so much, Dale. We really appreciate it. And we'll hope to see you all next time for a community conversation and our networking in April. So check out the calendar. Actually, Sophie, maybe you can put a little link to the calendar in there. And yeah, we will talk to you all next time, and enjoy the beginning of spring wherever you are. It's
Yeah.
definitely popping up.
Yeah, it is. And,
Okay.
and yeah, thanks to Sophie for joining and helping us with this, and to Beth for moderating.
Yes. Thanks,
Yes.
Sophie. Yes. All right.
Bye, you guys.
Thanks, everyone. Bye-bye.